Hello. So today I'll be talking about imaging in the diagnosis of abdominal pain due to parenchymal organ distension. This will be part 2.7 in an approach to vomiting and abdominal pain. So in one of our previous discussions, I had discussed this particular case of a 46-year-old gentleman with no known prior comorbidities who presented with abdominal pain for the last 2 to 3 weeks, which was gradual in onset, persistent, non-progressive, deep-seated, left upper quadrant, dull aching or catching type of moderately severe abdominal pain, radiating to the left shoulder. The pain showed sudden worsening over the last 2 days, and there was a sharp increase in the severity of pain with deep breathing. So we essentially localize this pain to be arising from either the spleen or the left kidney, and then because of not the negative history of no alteration in color of urine, passes of stones or pus in urine, or decreased urine output, we essentially decided that the likely pathology is diffuse splenic inflammation or splenic infarction. Now, importantly, as the splenic size was normal, that is, it's not a large spleen, the infarction is not likely due to secondary to splenomegaly, and the workup that was advised was imaging. So we take this up from there, and we find that this is what it leads to. So we've already discussed in the previous video in this series. We've reviewed the anatomy of the liver, general features of contrast and imaging of the liver, role of imaging in the diagnosis of biliary tract obstruction. We've described the role of imaging in the diagnosis of hepatic venous obstruction, and then differentiated Budd-Chiari syndrome from elevated right atrial pressure as well as sinusoidal obstruction syndrome or other hepatic venous outlet obstruction syndromes. So in this particular discussion, I would like to go ahead with the remaining topics, that is, discuss the remaining imaging of the spleen as well as the kidneys. So that will be done under the following headings. First, we'll talk about the role of imaging in the diagnosis of diffuse splenic disorders. Then we'll talk about role of imaging in the diagnosis of diffuse renal parenchymal disorders. Within that, we'll talk about the general features of contrast enhanced imaging in the kidney. We'll talk about findings that are specific to pyelonephritis, and then we'll talk about the role of imaging in the diagnosis of renal and splenic infarction. So again, we discussed renal, pyelonephritis, acute pyelonephritis as its own entity, and therefore it requires the detailed discussion of its imaging as well. So jumping right into it. Imaging in the diagnosis of hepatic, diffuse hepatic or splenic parenchymal disorders. Now, why hepatic also? Because we'll see that it'll become apparent in a few slides from now. Okay, so the quote-unquote normal spleen essentially is a normal size splenic size of 12 into 4 into 7 centimeters. Okay, the splenic quote-unquote volume, obviously this is an abstract or rather arbitrary way of going about describing it, is basically the anteroposterior diameter times the transverse diameter times the craniocaudal diameter divided by 2. Okay, now the normal volume comes out to be around 200 grams. So again, it's not volume, it's given as a mass. Two variations are common and they do not represent pathology. One is the presence of an accessory spleen. The second is the presence of splenic lobulations, because as most of us know, the spleen arises from multiple splenic precursors, around 8 of them, which then fuse together. So if the fusion is incomplete, you get lobulations. So accessory spleens are usually less than 3 centimeters in size and located in the hilum of the spleen, and they enhance like the spleen, which is something that I'll just describe. Splenic lobulations are clefts that separate the normal splenic parenchyma. Essentially, they're literally of no clinical importance except for when you're considering the possibility of a splenic laceration. So again, accessory spleens need to be differentiated from neuroendocrine tumors, and for this you can do chromium labeled damaged RBC scans. Again, splenic lobulation can simulate laceration and very rarely an infarction. Okay, so now when we evaluate the spleen, an important caveat to imaging is that more than 99% of splenic lesions are benign, and essentially diffuse splenic processes are more often than not going to also involve the liver. So as a doctor, who practices internal medicine, rheumatology, for me the most important thing when I look at or I think about a lesion affecting the spleen is whether or not the liver is affected, because if it is a multi-system disease, it is likely to help me narrow down the differentials, and this is how I approach it right off the bat before I look at anything else, any of the imaging findings. Obviously I'll have a clinical differential diagnosis, but that narrows down, and I slim down the differentials using the the following this diagnostic framework. So the first step to consider is whether or not the lesion was an incidental finding. So if the lesion was detected incidentally, then essentially you need to have a very, you need to, usually it is of no value, and therefore you can just wait and watch. You can discuss it with a radiologist, and depending on what the radiologist says, you can consider re-imaging in 1 year. If the lesion was detected due to some clinical findings such as fever, generalized generalized lymphadenopathy or hepatosplenomegaly, in that case the evaluation is heavily dependent on clinically determined pretest probability, which we've already discussed in the preceding videos in this series. Imaging findings that are more contributory than others are as follows. These are findings that would make me want to take a histopath of the spleen in these particular situations, and that would actually imply that I would want a splenectomy and a splenic or and a histopathological evaluation of that. But again, a splenectomy is a very invasive procedure and leaves a patient immunocompromised for their entire life. So it is something that we need to consider with, the risk versus benefit has to be considered in all cases. Now, in some situations, however, it may not be required. So the situations in which the imaging findings are relevant while evaluating a patient, that is splenic lesions that have been detected in a patient with some symptoms, okay, are relevant if they are one of four types of findings. That is, one is naturally generalized lymphadenopathy and hepatosplenomegaly, and we have an entire series dedicated to that. Then we have simultaneous involvement of both the liver and the spleen, and like I just mentioned, that helps us as internal medicine doctors narrow down the differential very significantly. Third, we have lesions with imaging findings that are suggestive of infections, or specifically a liver splenic abscess, and then we have imaging findings that raise suspicion of a malignancy. Sometimes after discussion with radiology, we can consider evaluation of splenic lesions, but again, this is best left to the radiologist. I usually prefer not to go down this road. Okay, so I usually do not go down this road. However, there are some clinical situations in which it becomes relevant, and when we discuss generalized lymphadenopathy and hepatosplenomegaly, those situations will become abundantly clear. Okay, so in our case here, we'll be concentrating on the last three findings, because again, we have an entire series dedicated to approach to generalized lymphadenopathy and hepatosplenomegaly. Okay, so jumping right into it, the differential diagnosis for a case, in any case where there is pathology that is involving both the liver and the spleen, there the differential diagnosis is SLIM. Okay, so what does SLIM stand for? SLIM. S stands for sarcoidosis and other granulomatous disorders. L stands for lymphoma. I stands for infection, and M stands for metastasis, more generally malignancy, but metastasis specifically. Now, specific etiologies that need to be considered are as follows. So in case of naturally sarcoidosis, we need to think of sarcoidosis, and we need to think of other granulomatous infections. Now, these granulomatous infections are obviously likely to produce necrotizing granulomata, and that necrosis is often describable, at least imaging wise. So that, as we'll discuss in our the mechanistic understanding of infectious disease later on, would be the following diseases. That is tuberculosis, mycobacterial tuberculosis more than non-tubercular mycobacteria, nocardiosis, brucellosis, amyloidosis, acute Q fever, and fungal infections. Now, sometimes you get granulomatous infection even without necrosis, and that specifically occurs with atypical cat scratch disease, which is an extremely rare thing, so we don't really need to consider that. But TB, especially in India, becomes a very major consideration in all cases. In case of lymphomas, the lymphomas could be or almost exclusively B-cell lymphomas. They could be Hodgkin's and non-Hodgkin's. Again, we will have an entire series dedicated completely to this. Then among infections, now if you have multiple lesions within the spleen and the liver, you must consider disseminated fungal infections, particularly in immunocompromised patients, actually exclusively immunocompromised patients. So that would be disseminated candidiasis and progressive disseminated histoplasmosis. And finally, we have metastasis. So now metastasis to the liver is possible in the following cases. So we have these possibilities. Use a mnemonic: possible. So P stands for prostatic malignancies, O for ovarian, S for stomach, again S for and I for skin, specifically melanoma, B for breast, L for lung, and E for extension from nearby organs. Okay, so obviously the liver and the spleen are right next to each other. So say locally advanced malignancy around the cardia of the stomach might affect both. Okay, so that's that. Now, however, in almost all cases, isolated splenic lesions are of little clinical relevance. Most of these lesions are just one of three lesions, that is a cyst, a hemangioma, or a hematoma. Now, they're actually relatively easy to differentiate from each other. Cysts are usually single, maybe multiple. Hemangiomas are mostly single, but there are some clinical syndromes in which you have multiple, like Klippel-Trenaunay-Weber syndrome. Then we have hematomas, usually single, can be multiple. Again, if they are multiple, hematomas of the spleen typically occur in other disorders with hematomas, like tuberous sclerosis, and they occur with viscoelastic syndrome. This is important from immunology, from the perspective of clinical immunology and rheumatology. Then now the next thing is, on a non-contrast image, what do you find? So on a non-contrast image, what we find is a lower density as compared to the rest of the spleen. So the differential diagnosis of this is a splenic abscess, and we will see what features suggest a splenic abscess in such a situation in the next slide. Then we have hypodensity, which is there in hemangioma. Hematomas are typically isodense to hypodense. Once we start looking for contrast enhancement, cysts usually don't show contrast enhancement. Hemangiomas show early peripheral enhancement, usually in discontinuous, which is called puddling, which then extends centripetally, though not always, and eventually it becomes isodense to the blood pool. So larger lesions sometimes have a central scar. Okay, we'll see similar lesions in the imaging of the of lesions, of space occupying lesions within the liver in an appendix of this series. Then we have hematomas, which essentially enhance slowly. They may show peripheral to centripetal enhancement, and therefore they can mimic hemangiomas, but again the rate of filling is actually quite slow. Then we have his morphology. So cysts are typically very sharply demarcated lesions. They don't cause much architectural distortion unless the lesions are very large in size. Hemangiomas may or may not cause architectural distortion, cannot really be commented upon. Then hematomas are usually not sharply demarcated, whereas hemangiomas are relatively sharply demarcated, and hematomas tend to actually push away structures from the spleen. So they tend to abut, say the stomach, they push into the stomach, so they jut out of the outline of the spleen. Now, the differential diagnosis of a splenic cyst are, I remember them because they look like peaches. So it's a peach of a diagnosis. So P stands for post-traumatic cyst. Can also stand for pseudocyst, although pseudocysts usually occur outside of the spleen. E stands for epidermoid cyst. A stands for abscess, and we'll see how to differentiate it from cyst. C stands for cystic degeneration of an infarcted spleen, which will be obviously the last topic in this discussion. Then we have hematomas. Now, importantly, older hematomas tend to show calcification, and this is actually a pretty dead giveaway as far as hematomas are concerned. Now, finally, you can also have cystic lymphomas and cystic metastasis, but again, there would be some, in case of metastasis, there would be other possible differentials, as in the pun intended. And in case of lymphoma, usually the spleen is enlarged, there's generalized lymphadenopathy. Okay, there are other findings of malignancy. Okay. Now, in case of hemangiomas, there are three essential differentials that need to be considered, although in most situations they are not that difficult to differentiate. One is extramedullary hematopoiesis. Naturally, there will be a specific clinical setting in which this would occur. Second is what is called a Sant lesion, that is a sclerosing angiomatoid nodular transformation, which is basically a type of hematoma with more of a more vascular or red pulp like differentiation. Then we have hypervascular metastasis, typically from an RCC, can also be from a melanoma or a follicular carcinoma thyroid, although that's a very rare site of metastasis for the same. Now, so when you have a benign lesion of the spleen, essentially what you're interested in is it really benign or not? So, or rather, is it of clinical significance or not? So it could be of clinical significance in two situations. One is if there is a naturally if there is a splenic abscess or a malignancy, and the other is malignancy. So there are three clinical findings or radiological findings that strongly suggest or abscess or a malignancy, that is a lesion that is poorly demarcated. The second thing is significant perilesional edema around any lesion within the spleen, and the third is an extension to adjacent structures. Now, another thing that I actually was planning to mention in the beginning of the talk on the spleen was the pattern of enhancement. So the spleen, typically, if you take very early arterial sections of the spleen has got two separate circulations. It's got an open circulation and closed circulation, and it's got the arterioles that are directly going into the venules, and then there is the open circulation in which the blood opens up into the interstitial space and then comes back through lateral cells. Okay, so we'll discuss that in our series on in the immune system. So because of that, there are two, when you give contrast into the spleen, especially early on, the rates of contrast entry into different parts of the spleen that are right next to each other are slightly different. Okay, so that ends up producing a alternating pattern, okay, which classically, or at least generally speaking, is what is called a Moret pattern. Moret, okay, with an apostrophe on top, so that's a Moret. Okay, so the Moret pattern is specific for the spleen, and very early arterial phase cuts through the spleen will show this, and eventually the spleen becomes isodense with the blood pool, so that becomes a normal pattern. Okay, now obviously in both of these lesions, malignancies and abscesses, will not show that kind of a enhancement pattern. This is particularly the case. The second point, that is the features that are specific for malignancy, is hypervascularity. Now, hypervascularity would show almost like a light bulb. The spleen the lesion picks up contrast. So that kind of hypervascularity is actually quite specific for neuroendocrine tumors. Again, we'll be delving into gastrointestinal tumors, their molecular pathogenesis, genetics, and imaging in an appendix to this series later on, but I don't want to go too much into detail there into that right now. Usually in most such clinical scenarios for internal medicine, we don't come across those things, and when we do, we require a slightly senior person to discuss it with. So that is something that we'll come to later. Okay, now shifting focus to the imaging of the of diffuse parenchymal lesions of the kidney. Now, obviously, naturally, it consists of two types of lesions. One is your acute interstitial nephritis, which we already discussed in our approach to pedal edema, and then the sub discussion or the subtopic of an approach to oligurorenal failure, and pyelonephritis and with or without renal abscess we'll have to discuss here. I have already discussed the clinical aspects of this before, so I'm going to concentrate on the radiological aspects. So see, as you give contrast into a patient, the kidney actually enhances in some very specific phases. Okay, so initially, so this is a non-contrast, this is without no contrast, so this is non-contrast. Okay, and then what we did is we've given contrast to a patient. The rates don't really matter. Okay, it's not really important for internal medicine people to know. Radiologists know how to do their job. So essentially what happens is initially, obviously, the contrast reaches the afferent arteriole and then the capillaries of the glomerulus. Now, more obviously, all the glomeruli are located within the cortex of the kidney, so this diffusely enhances the cortex of the kidney, but the contrast has not reached the medulla, so this enhances the cortex, does not enhance the medulla. After that, the contrast gets filtered because it's water soluble. Okay, and so because it is filtered, it gets into the Bowman space. Some of it also remains in the circulation and goes through the vasa recta, into the renal medulla, but again that's just 1% of the blood flow of the kidney, so it's not really that significant. The main thing is the filtration. Okay, so that results in almost somewhat of an equalization between the cortex and the medulla, but there is still a difference. Finally, what ends up happening is that most of the contrast gets either goes away from the kidney via the venous flow, or it gets filtered and then accumulates within the collecting system, highlighting the collecting system. So we end up with these 4 phases of the kidney after contrast enhancement. So the first phase is what we call an unenhanced phase, as would be expected. Then we have what is called the corticomedullary phase, because it helps you differentiate between the cortex and the medulla. And then we have what is called the parenchymal phase, also called the nephrographic phase. And then we have the excretory phase, which is self-explanatory. So these are the 4 phases, that is unenhanced, corticomedullary, parenchymal, and excretory. So now this is what it looks like in a real image clinically. So the corticomedullary phase, as you can see, it's quite clearly demarcated. The differences between the cortex and the medulla are quite clearly demarcated. The cortex is intensely enhancing, the medulla is yet to enhance. Then we have the parenchymal phase. So the parenchymal phase, again, you see that the corticomedullary differentiation is now lost. The medulla is still slightly less enhancing, but the cortex is slightly less. It's actually more enhancing than it was, and the cortex is now slightly less enhancing. So the difference is decreased. And finally, we have the excretory phase, in which all of the contrast is accumulated within the collecting system of the kidney. Okay, so if you plot this against time, and the y-axis here is Hounsfield units, okay, the amount of contrast or X-ray attenuation that the contrast is causing, what we find is that cortical attenuation initially increases rapidly. So it goes rapidly like this, okay, reaching a maximum of around 185 HU, Hounsfield unit, by between 40 to 60 seconds, whereas medullary contrast enhancement takes time. Okay, so if you were to take take an image between say 25 and 50 seconds after contrast injection, what you would get is naturally the corticomedullary phase, because the cortex would enhance and then the medulla would not, and that is what this looks like clinically. Similarly, if I was to take an image between 50 and 60 seconds, now the cortex is going back to its attenuation is decreasing, and the renal medullary attenuation is now almost constant. So between 60 and 90 seconds rather, you would end up getting what is known as the parenchymal phase, and the parenchymal phase is also called the nephrographic phase. And as you can see, there is still a difference. Still a difference between the cortex and the medulla. The cortex is still more enhancing than the medulla because it has much more blood supply, but the medulla has caught up in terms of attenuation, and the cortex has gone down. Okay, so this is the corticomedullary and parenchymal phase. It's very important to understand what that represents. So now again, to drive home the point, corticomedullary phase is on the left side, and that is what it looks like. And then we have the nephrographic phase on the right side, and that is what it looks like. The parenchymal phase on the right side, and that is what it looks like, and that is what is happening. As in the corticomedullary phase, there is contrast within the glomerular capillary bed, yet to be filtered adequately. And then eventually we have the nephrographic phase, in which we have contrast that has been filtered and has reached the collecting tubules. So now this is interesting. What would determine the rate at which this transition occurs after some contrast has been given intravenously to a patient? So naturally it would be the glomerular filtration. Okay, so essentially the rate of filtration transition essentially depends on the glomerular filtration rate, and this in turn then depends on, as we've discussed in our approach to oliguric renal failure, it depends on, we meet our old friend, the cross section to a glomerular capillary tuft, and we find that the filtration occurs from obviously inside the blood vessels. So this is inside the blood vessel, and this is outside the blood vessel. This is the Bowman space. And the pressures that determine this are the pressure within the Bowman space, that is P Bowman space, the pressure within the capillary of the glomerulus, that is the P glomerular capillary, and naturally the equation that determines this is the GFR is equal to filtration constant K times the difference between the pressure within the glomerular capillary and the pressure within the Bowman space. And we talked about it there that the pressure within the Bowman space only increases when there is a distal obstruction. Okay, so if there is a distal obstruction distal to the kidney, that will cause increase in pressure within the Bowman space. Therefore, the difference between the pressure, the difference between the pressure within the glomerular capillary and the Bowman space would decrease, and therefore filtration would decrease. Okay, so that is pretty self-explanatory, and therefore there would be a time delay. Okay, there would be a delay in the rate of shift from this corticomedullary phase to a parenchymal phase, and that is something that we can pick up on radiology. Okay, now an increased Bowman space pressure naturally implies either distal tubular obstruction or interstitial edema compressing the tubules from outside. Okay, so tubular obstruction due to something going into the tubules getting deposited there, or the tubular epithelial cells getting desquamated and obstructing the tubule. The edema within the interstitium of the kidney compressing the tubules from outside, or obstruction much more distally, that is a distal urinary tract obstruction. Okay, so essentially decreased peak glomerular pressure decreases only when there is a decrease in the perfusion pressure of the capillaries. So that could happen with any hyperperfusion state and with renal artery stenosis. Okay, or even afferent arterial stenosis, like in hypertensive emergencies. So that is something that is not relevant to this particular discussion. Okay, so let's move ahead. So what would be the findings in cases of pyelonephritis? So in case of pyelonephritis, say we have a hematogeneously spread infection. Okay, there is hematogenous spread of a pathogen into the kidney. Okay, and then that kidney, that pathogen then breaks through the vessel wall, or eventually gets seeded within the interstitium. Similarly, you could have an ascending infection up from the distal lower urinary tract into the tubules. So that is what it looked like, and again from the tubules the infection would come into the interstitium. So how that would happen is, an infective agent would first of all attach to the epithelium or to the vessel wall. There would be an immune response against it that would contain neutrophils. Neutrophils would come and break down the cells to which the pathogen is attached. So that would open up the area for the pathogen, and that's how pathogens get how interactions of the immune system with the pathogen result in local abscess formation. So obviously not all pathogens are capable of doing this, but the ones that are that way, they cause a lot of problems. So now that the pathogen is in the renal interstitium, naturally the immune system again detects the pathogen, and innate immune activation occurs. So innate immune activation will result in vasodilation and because of pro-inflammatory cytokine release. That pro-inflammatory cytokine release will result in capillary leak. Okay, so the vasa recta, the capillary bed in the interstitium starts leaking fluid, and as it leaks fluid, that increases the pressure within the interstitium of the kidney. That increase in the interstitial pressure compresses the tubules, so the tubules essentially collapse. Okay, and that causes back pressure, and there is a backup of filtrate, and that backup of filtrate results in an increase in the Bowman's pressure within the Bowman's capsule. Okay, so that will result in decreased perfusion. Now, naturally, in case of an infection, this would not happen everywhere. This would happen in parts of the kidney. Okay, so some parts of the kidney would be relatively fine. Some parts of the kidney would be affected more. So you might have areas within the same kidney. Okay, or maybe one kidney is affected and the other kidney is normal. So either way, there would be a discordance in the rate of shift from your corticomedullary phase to parenchymal phase, either between the kidneys or between one part of the same kidney and another part of the same kidney. Okay, so so as a result, there will be a decrease in the perfusion pressure, and that will result in a delay. Okay, now this is because of a delay in the filtration of contrast in the glomerulus, and that resultantly causes a delay in the shift from a corticomedullary to a parenchymal phase. So naturally, what would you expect if you had pyelonephritis in a patient with and you do a CECT in that patient? So in the corticomedullary phase, what we find is that an area of the kidney, the rest of the kidney is showing good corticomedullary differentiation, but area towards the back of the kidney, or the left kidney, is showing absence of corticomedullary differentiation. So that absence of corticomedullary differentiation is because of it's just not taking up contrast. So that is what you find. You see a loss of the corticomedullary differentiation that you expect. Okay, then we have the parenchymal phase. So in the parenchymal phase and the excretory phase rather. So in the parenchymal phase, we find that the corticomedullary differentiation in the parenchyma is actually maintained for longer. Again, the transition from the corticomedullary phase to the parenchymal phase has been delayed. So normally when you expect the parenchymal phase, you still have a corticomedullary phase. Okay, and then in the excretory phase, we see a classic quote unquote striated nephrogram. That was described by Bosniak actually on X-ray pyelography, but the principle remains the same. So here what ends up happening is that contrast is getting excreted at slower rates in those tubules that are compressed because their resistance is higher, whereas it has been excreted from the ones that don't have increased interstitial pressure around them. So you get a striated appearance in the excretory phase. And specifically the excretory phase striated nephrogram is actually the most specific imaging finding. So if you had needed one phase of contrast enhanced imaging to say whether or not a patient has pyelonephritis, it would be the excretory phase. Okay, so that is something very important, and technically that's a MCQ. Okay, so the single best phase to image in cases of pyelonephritis would therefore be the excretory phase. It has a high negative predictive value. If this striated nephrogram appearance is not there, you must strongly reconsider the diagnosis of pyelonephritis. Okay, now there are some other findings, some morphological findings that are present on even non-contrast imaging, and actually see it's present even on ultrasonography, and a lot is said about this, maybe a little bit too much. Okay, but these findings lack the specificity that people think that they have. The findings are pretty obvious. One is perinephric stranding. So we've discussed what stranding is when we talked about imaging of the pancreas. This is essentially accumulation of fluid which has higher density, X-ray attenuation in the septa separating fat lobules in the perinephric fat. So the fat has got lower X-ray attenuation and the fluid has higher X-ray attenuation. This produces a wispy appearance in the fat around the kidney. So naturally this could be due to inflammatory fluid leak due to any reason. Okay, so this could be perinephritis due to anything. This could also be a mass lesion, malignancy with neovascularization and leaky capillaries. It could also be the hairy kidney sign which occurs in your Erdheim-Chester disease, and again this is a little rare. The hairy kidney sign does not, the wisps are actually very sharply demarcated. These are fibrotic foci fibrosis, so they have a very distinct appearance. So it's much more prominent. There's a widening of the perinephric tissue, and there are other findings about Erdheim-Chester. So it's not that easy to it's not that difficult to differentiate these two. The second thing is a decrease in the attenuation of the renal tissue on non-contrast imaging, obviously because there is accumulation of fluid within the renal parenchyma. So, and this is due to interstitial edema. See, again, now naturally it is natural to think that fluid, in case of perinephric fat stranding, I said that fluid is increasing attenuation. That is in relation to fat. Fat has much lower attenuation than fluid, so therefore accumulation of fluid results in increase in attenuation of those areas, whereas the renal parenchyma has got higher attenuation than just water or fluid. Okay, so naturally that results in relative attenuation, so that's the reason. Okay, so that could be a renal abscess. We will not be able to differentiate. Renal abscess can only be differentiated based on the absence of uptake of contrast in the center of the lesion. Okay, indicating necrosis. Then we have alterations in renal contour and size. So the kidney could get enlarged in size. It could change its shape. Okay, and that happens because of either due to fluid accumulation in case of pyelonephritis, but it can also happen with renal mass lesions, and it can happen with abscess formation. Now again, I'll just summarize these using an image. So this is a kidney, and the right kidney here, as you can see, is showing a lot of perinephric fat stranding and decrease in tissue and attenuation in these areas. So I'll just highlight those areas. These specific areas within the kidney show decreased attenuation. Now on the right we have a contrast enhanced image showing a altered renal size. So you can see the left kidney in this particular case is larger than the right kidney, and importantly there is prominent fat stranding, these tiny wisps of tissue that are going out of the left kidney. So the left kidney is naturally that is the one that has pyelonephritis. Okay, but again these are not things that these are not very specific, and what is specific is what we see in contrast enhanced imaging, because that is an indicator of the altered physiology that is occurring. Okay, so that's your perinephric fat stranding. Okay, now coming to the third part of our discussion today, that is arterial ischemia in the kidney and the spleen. So how you define these ischemic infarcts of the renal and the kidney and the spleen is by their sharp demarcation. So there's another thing in case of the kidney, because usually the one of the arteries to the posterior aspect of the kidney, the arterial branches of the renal artery, is often given off very proximally to the origin of the renal artery. So renal artery obstruction distal to that results in sparing of some of the blood flow to the periphery of the kidney. Okay, so you end up getting what is called the cortical rib sign. This is a thin rim of hyper enhancement. So it's very subtle, at least in the image that I'm showing, but there's a little bit of hyper enhancement in a rim here with a sharply demarcated hyper enhancement here. Okay, so this is what we call the cortical rim sign. And in case of a splenic infarct, this is just a wedge shaped infarct, again because the blood supply to the spleen comes like this. Okay, so when one artery is gone, there will be a wedge shaped infarct in the reaching up to the subcapsular area of the spleen. Okay, and we've discussed what the clinical relevance of all of this is, what evaluation would be required and what evaluation would not be required. Okay, now a special sub variation of this kind of splenic infarction is something known as a migratory spleen that then rotates on its axis, so you can get a total infarction of the spleen in that situation, and that is something that can present as a focal localized abdominal pain plus or minus vomiting, and because the spleen is migrating, as in the splenic suspensory ligaments are very long, often the pain is not localized to the left upper quadrant, so it could be in some other part of the abdomen. So that is something that can cause confusion. However, radiology usually clears that up quite easily. Okay, now coming on to the next topic. So summarizing what we've discussed till now. Previously we talked about all of these things. Today we talked about the role of imaging in diffuse splenic disorders. Okay, we talked about the slim differentials. Then we talked about what might trigger us to think about inflammatory pathology and mass lesions within the spleen. Then we talked about the role of imaging in diffuse renal parenchymal disorders, with special emphasis on the general features of contrast enhanced imaging. Then we talked about findings specific to pyelonephritis, tried to derive it from there, and we talked about the imaging of renal and splenic infarcts, which was relatively easy to understand. Now, so based on what we already know, this patient of ours, as we said, required imaging, and based on the imaging we further would decide whether or not so on the history only it is quite obvious that the patient has developed a splenic infarct. Okay, so what was the cause of the splenic infarct and how would you go about it, it would be important, and particularly if the liver and the spleen were both affected. Okay, that would make us differentials slim. Okay, and that would be something that would be very important. Okay, so again, in the different clinical scenarios that we've discussed, that would help us narrow down the differentials very significantly. So that would be enough for this particular discussion. However, I have a special topic to discuss, that is there are three radiologically and therefore pathologically defined variants of pyelonephritis. Okay, one is emphysematous pyelonephritis, the second is xanthogranulomatous pyelonephritis, and the third is renal tuberculosis. Xanthogranulomatous pyelonephritis and renal tuberculosis are actually chronic diseases, so they produce chronic poorly localized pain usually, so I'm going to be discussing it there. Emphysematous pyelonephritis will be covered here, so we'll get into that. Okay, and this is a very important subvariant of pyelonephritis, which is often first brought up by the radiologist, but there are you should at least clinically in internal medicine suspect it prior to the radiologist picking it up. Okay, so why is there emphysema? Why is there air within the inflamed kidney? So more than 90% of patients with emphysematous pyelonephritis have diabetes mellitus, usually with a poorly controlled status, that is an HbA1c more than or equal to 8. See, in older people and slightly older people, 8.5 might be your target as it is. So in older people, even with relatively well controlled diabetes, you can have this. Okay, so because of that, what ends up happening is that obviously for various reasons that we'll discuss in detail when we talk about diabetes, there is an increased risk of a ascending infection. Okay, and that most commonly happens to be whatever is there in stool, that is E. coli and Klebsiella pneumoniae. That ascending infection that we've discussed already would normally be responded to by neutrophils, but diabetics have poor or impaired neutrophil responses. So because of that, there is, before such a response develops, there is extensive bacterial proliferation. Now that extensive bacterial proliferation is also aided by the presence of increased the abnormal glycemic status of the patient. That then results in secondary very significant tissue necrosis, both because of bacterial enzymes and reactive oxygen species, and the delayed but prominent, as a result of the requirement for the response to be prominent, delayed but prominent neutrophilic response. So that necrosis eventually results in a lot of necrotic material being present there, and bacteria that have really not been killed, and those bacteria then ferment whatever organic material, the amino acids, the fatty acids that are there, and to some lesser extent carbohydrates that are there, and they produce carbon dioxide and hydrogen gas. Okay, so now on top of that, obviously diabetic patients obviously have also got something called diabetic microangiopathy. That microangiopathy results in vascular insufficiency, and the air, therefore, that would result in vascular ischemia of this tissue, and that would enhance the tissue necrosis, but it also impairs the removal of air from the area, resulting in accumulation. Okay, so as a result of that, there is decreased reabsorption of air from the tissue, and as a result of that, there is accumulation of gas within the renal parenchyma. Okay, now this accumulation of gas within the renal parenchyma can actually, through its physical effects, cause local extension, and eventually the gas can then seep into the perinephric tissues, and then even outside of the kidney into the retroperitoneal space. Now there's another risk factor that is often missed in case of emphysematous pyelonephritis, that is obstruction of the urinary tract, and due to urolithiasis. Although not common, patients with relatively controlled glycemic statuses can also develop emphysematous pyelonephritis if they have significant urolithiasis, although again this is debatable. Okay, so that is the entire pathogenesis. And how obstruction causes this is by causing interstitial edema, which obviously compresses blood vessels from outside, causing microvascular occlusion and microangiopathy. Okay, now clinically, you really can't expect this, so except based on the risk factors and the severity of the patient's clinical presentation. Okay, so the constitutional features, whether or not the patient has developed shock, things like that. Okay, so eventually you obviously will go ahead and do an imaging, and in the imaging you will be classified patients based on into 5 classes. That is, this is based on a classification that was proposed in this particular article that I've referred below, and this is standardized now. So basically we have class 1, that is emphysematous quote unquote pyelitis. So this is just gas confined to the collecting system, in which case we just need to give IV antibiotics and do a percutaneous drainage and nothing else. Okay, second is class 2, when it is gas. This is the real, this is where real pyelonephritis, emphysematous pyelonephritis starts. This is confined to renal parenchyma. So the fact that the the capsule of the kidney has not been breached is a very important thing. Okay, if it's not been breached, we can do percutaneous drainage and IV antibiotics, give antibiotics. But if it has been raised, if it has been breached, as in class 3A, that is, there is extension into perinephric fat. Okay, or in 3B, when there is extension through perinephric fat and gyratosis fascia into retroperitoneal space, or if there is involvement of both kidneys, because in case of both kidneys, obviously the renal function will start getting deranged, and then the patient could go into renal failure. Or a single kidney in a patient, in a patient with single kidney, if the functioning kidney is affected. In all of these cases, we do all of the above, that is, we give fluid resuscitation, IV antibiotics, and try percutaneous drainage. But sometimes we have to do a nephrectomy. Now, there are some absolute indications for nephrectomy. This is any one of the following, that is, the patient has developed altered metastasis, essentially if the patient has gone to septic shock. So A standing for altered mental status, B for BP, but this is systolic blood pressure less than 100 millimeters of mercury, C for creatinine elevation, that is any type of azotemia, and D for decreased platelets, which would indicate that the patient might be going into DIC. D also stands for dry type disease, and dry type disease essentially means that there's not significant amount of perinephric fat standing and things like that. Okay, so that portends a worse prognosis. So again, in that situation, especially if it is unilateral, we try to remove the kidney. Okay, now there is a novel mortality score that was recently proposed based on a longitudinal study, which is something that I would want to highlight, because that helps us clinically in internal medicine. So I use a mnemonic ABCDEF for it. A would stand for anemia, B stands for bad QSOFA score, C stands for counts, that is total counts more than 22,000, D for decreased platelets, E stands for extension outside the kidney, and F stands for a fasting blood sugar or other glucose measurements being deranged. Okay, so even during the acute episode, the level of glucose derangement becomes important. So there we give a point each for all of these, except for bad QSOFA more than or equal to 2, which gets a point of 2. Gets 2 points. Okay, so if you add all of this together, you can then subclassify the patient as having less than or equal to 3 points, which would mean less than 5% mortality. 4 points, which would mean shooting of the mortality shoots up to 36%. 5, which again there is it exponentially rises to 63%. 6, in which case it is 83%, and when it's more than or equal to 7, it's essentially 100%. Okay, so the presence of these 6 parameters strongly predicts, prognosticates, helps you in prognosticating the patient and predicts outcome. And I use these clinically whenever I come across emphysematous pyelonephritis, and something that should be known. Okay, so now that we've discussed emphysematous pyelonephritis, later on when we talk about chronic multifocal or poorly localized, or rather multifocal abdominal pain without vomiting, we'll be talking about xanthogranulomatous pyelonephritis, and we'll talk about renal tuberculosis separately. Okay, so that brings me to the end of this discussion. I hope things are clear, especially the dynamics of contrast enhancement in various phases of renal enhancement. So I'll see you in the next video. Thank you for watching.